Welcome to this evening's webinar, Women's Health 2025 Update, Managing Menopause and Stress Urinary Incontinence. My name is Serena, your RCGP representative for this evening. We are joined by our presenters, Dr. Vincent Tse and Dr. Vivian Yang, and GP facilitator Dr. Joanna Bruce. Before we get started, I would like to make acknowledgement of country. We recognize the traditional custodian of the land and sea on which we live and work, and we pay our respects to elders past, present, and emerging. I myself am joined from Gadigal land located in Sydney CBD. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. I'd like to introduce you to our presenter for this evening. Dr. Zhe is a consultant urologist and an expert in bladder dysfunction, urinary incontinence, pelvic floor reconstruction, and robotic surgery. Dr. Zhe practices at Macquarie University Hospital and is also associate professor at the University of Sydney Concord Clinical School. Dr. Yan is a gynecologist following her graduation from the University of Sydney in 2000. Dr. Yan completed her specialist training in obstetric and gynecology. This was followed by further training in advanced laparoscopic surgery and pelvic floor surgery at Westmead, St. Vincent's, and the Royal Prince Alfred Hospitals. Dr. Bruce has been a doctor for 30 years and a GP for 20 years. She is the censor of RCGP for the New South Wales ACT faculty and the owner of a GP-led peri and menopause clinic. Welcome to all presenters. I will now hand it to Jo, who will go over the learning objectives.
Thank you, Serena. So thank you for everyone for coming tonight. There's quite a number of you online. So we're going to have a whistle-stop tour between about symptoms of perimenopause and menopause and supporting the timely intervention, looking at some evidence-based approaches to support women during this period of time. And then we're moving on to evaluating stress incontinence and looking at a contrast between different types of non-surgical and surgical treatments. So all stuff that we see every day in general practice. And I'm going to hand over to Dr. Yang now to start the presentations. Vivian, you're on mute.
Sorry, yes. Hi, sorry for joining. Thanks for joining us on the evening. Today I'll be talking menopause. I think there has been quite a lot of women seeking menopausal management. You probably know it firsthand more than I do. I'll quickly move on. Disclaimer, I'm on HRT and I intend to be on it for long term. So that would be the take-home message. Historically, look, I think there has been a lot of sexism, like women's identity and health was based on the balance between estrogen, lack of estrogen, and lack of estrogen was thought to be harmful socially and individually. Consequences such as untold misery of alcoholism, I don't know which part, male or female, drug addiction, divorce, and broken homes. So in mid-90s, 1940s, that's first time we had purpose-designed HRT. And by mid-60s, around 1/3 of UK women between age of 50 and 64 were taking HRT. It was then called HRT. But the uptake definitely was a lower in the low middle income countries. And even in the UK society, a lot of women didn't have a benefit. But still, uptake was quite high. But then WHI study came, next slide, in 2002. It was a very large RCT. The primary endpoint of the study was to find associated cardiovascular disease, protection of HRT. But the study had to be terminated prematurely in one arm, which the women who had an intake uterus, they were receiving combined estrogen and progesterone. So they realized they had about 26% increased risk of breast cancer. So that was terminated. However, another arm of that study, ICT, continued on. Those are the women who took estrogen only due to their previous hysterectomy status. But we now have a lot more long-term follow-up data from that same study. They all cause mortality, combined HRT. There was no increase after MHT, hormone replacement therapy. Next slide. So what's the definition of menopause? It's a clinical diagnosis of amenorrhea for 12 months, 1 year, and usually occurs between 45 and 55. Timing of menopause is slightly different from country to country. For instance, Indian community, the timing of menopause average age is slightly lower. And the perimenopause is a period leading up to the menopause. The year actually varies from person to person. During this time, what you're seeing clinically is irregular periods, but also hormonally, you see fluctuating levels of FSH, LH, and estrogen. But it can appear up to a decade early. Some people, they start to have perimenopause symptoms late 30s, some people in their early 40s. During this time, it's very difficult to make a hormonal diagnosis because the FSH level actually fluctuates, especially people who are patients using combined pills. So you have to exclude other causes, most commonly pregnancy, hypoprolactinemia, thyroid dysfunction, hypothalamic amenorrhea. Those are the common disorders you have to exclude. Next slide. So this is a nice diagram of women progressing through perimenopausal to early postmenopausal years. So stage -3 is a very early perimenopausal transition. They often have normal but variable FSH. Ovarian reserve starts to drop down, and they start to have irregular periods. It doesn't have to be a prolonged cycle. It could be quite common, like, frequent cycles. And then the move on to the early menopausal transition, there's more than 7 days difference in the cycle length. Once again, variable FSH. Ovarian reserve drops further. And then late menopausal transition, cycle length more than 2 months apart. FSH, this time it starts to have a consistently high level. And then early postmenopausal periods have ended. FSH is persistently elevated, and if you test ovarian reserve, it's very, very low to undetectable level. Next slide. So clinically, day-to-day basis, you only have a changes in menstrual cycle. FSH is not really that useful during this time. We don't normally test AMH in women of 45 years anyway. So hooking ovarian reserve, it's only useful like in study purposes. So menstrual cycle is the only clinical indicator you have of women going through menopausal transition. Next slide. So what are the common symptoms they present? Changing periods, prolonged menstrual bleeding is also very common, and most commonly what we call vasomotor symptoms, hot flushings and night sweats. It affects about 40%, and it peaks at a 60 to 80% 2 years after final menstrual period. The incidence is differ amongst different racial groups. There are a lot of other modifiable factors: stress, smoking, high BMI, their mood, anxiety level, and negative beliefs about menopause. And also commonly people complain sleep difficulties. In general, sleep difficulties is more commonly complained in women than men. But the one thing different during perimenopausal years is a frequent nighttime awake. People go to bed early and you wake up at 2, 3, a.m. and unable to return to sleep. And it can really affect daytime function. Next slide. Other symptoms include mood swings, irritability, low mood, and anxiety. People who already have underlying mental health disorders actually report worsening of their symptoms. Joint and muscle aches are more likely to be reported amongst Southeast Asian women. A lot of women that complain brain fogginess. Some of it is due to a poor sleep, but they have poor memory recall. And other genitourinary symptoms are very common: vaginal dryness, painful intercourse, urinary frequency, and this is when women starts to have recurrent UTI symptoms as well. It can be experienced up to 40%. And these are the symptoms that often persist into the old age. If not, some of those actually vaginal dryness and dyspareunia, they can get worse. And then low libido. Next slide. Thank you. So those are the short-term symptoms. What are the long-term health issues? Look, obviously loss of bone density. So you do have a 12.5% in lumbosacral and 1.8% femoral neck density loss in the first year of menopause. So this is a very important timing. And estrogen deprivation leads to increased bone absorption and decreased bone turnover. And I'll touch base later, but the MHT hormones, it reduces bone turnover, increased bone density, and lowers fracture risk. And it has additional benefit to your other osteoporotic medications. Look, this is one thing that's quite disappointing to a lot of women. Average weight gain is only about 1.6%, despite some beliefs. However, they do not increase central abdominal fat deposition. Insulin resistant and increased risk of type 2 diabetes. However, we do not have a clear evidence on the dementia and cardiovascular disease yet. Next slide. So when women come to you, you do your own health reviews, blood pressures, and other questionnaires, but they should be really assessed based in the basis cardiovascular disease risk factors, thrombophilic VTE risk factors, diabetic screening, and also cancer screening, cervical screening, and breast cancer screening as well. Next slide. So if they come with all these vasomotor symptoms, so what are the things we can do? We can offer, not straight to hormonal therapy, cognitive behavioral therapy, hypnosis, mindfulness, relaxations, lifestyle changes. They all have been tried and they're widely advocated. However, of those, only the first two, cognitive behavior therapy and hypnosis, have shown to be effective on a wide RCT. Weight loss, exercise, and diet, we don't really have RCT evidence on those. Stellate ganglion block is where you inject local anesthetic agent into the sympathetic nerve fiber of the neck. However, we do not really have a clear evidence on this either. It's only just a study purpose at the moment. Next slide, please. So, but there are patients who do not want to be on MHT or have their contraindications. So what complementary alternative treatments can we offer, or are they using? The herbal medicines, soy, phytoestrogens, evening primrose oil. However, we do not really have a good evidence on their safety and efficacy. And actually, some, the alternative treatments such as the phytoestrogens are contraindicated in breast cancer survivor patients. So, the women who already have a contraindication to hormonal therapy, they also have, the phytoestrogens, those alternative treatments, they're not indicated either. So we really do not have a clear evidence on this. Acupuncture, sometimes, there are a lot of evidence showing it's effective, but maybe due to placebo effect as well, because the ones who had they will have a sham treatment. So there's quite a high placebo effect in acupuncture. Next slide, please. So what are the non-hormonal pharmacological treatments for the typical hot flushings and night sweats? The common ones are SSRIs, SNRIs, escitalopram, citalopram, venlafaxine. They're all shown to be quite effective. However, we have to be aware of the side effects: nausea, dry mouth, constipation, sleep disturbances. SSRI, fluoxetine and paroxetine, they do impair conversion of tamoxifen to its active metabolites, so you have to be careful with those. Clonidine has been used for a long time for hot flushings. It's a centrally active, alpha-2 agonist. It's antihypertensive medicine. However, the side effects include dizziness, hypotension, headaches, constipation, and dry mouth. But they have been used for a long time, and they have shown to be very effective. Next slide. Gabapentin, pregabalin, useful. However, once again, side effects: somnolence, fatigue, and dizziness. And the next one is a Veoza. It's a TGA-approved medicine that has shown to reduce the frequency and severity of hot flushings. And a lot of patients are actively seeking this. Its safety has been proven. So it's something to look out for. Next slide. And then we move on to topical treatment, vaginal estrogens. if the woman doesn't have a lot of systemic vasomotor symptoms, but they just want something for their vaginal symptoms, dyspareunia or recurrent UTIs, their vaginal estrogens improve a vaginal dryness and sexual function, and there's no really increased systemic estradiol level. Safety data is limited, however, in general, is thought to be safe in general population, also breast cancer patients. Ovestin, vetiver, and pasteurized are most commonly used. There are a few over-the-counter vaginal moisturizers, most commonly Replens. However, we do not really have an evidence they lead to long-term clinical improvement. So they're not really better than any other lubricants. Next slide. Sorry, the slides have been mixed. So menopausal hormonal treatment, I want to focus a little more time on those. So what we know so far is the number one, endometrial protection is really important in women who has a intact uterus. Estrogen-only treatment should be offered for patients with prior hysterectomy, except the patients have a history of endometriosis. The woman who has a severe endometriosis, we have to use combined estrogen and progesterone. And same goes for women who's had a subtotal hysterectomy, supracervical hysterectomy, because they may have some of the endometrial tissue left behind. Risk of clot VT is definitely lower, if not at all, in transdermal estradiol. So nowadays, transdermal estradiol is a preferred route of application. Obviously, current breast cancer, is a contraindication. So one thing is a prescription of individualized and compounded hormonal therapy is not really recommended because we do not have a good evidence on those in terms of the safety. We now know in general that hormonal therapy prevents bone loss and fracture in postmenopausal women. Women with a high fracture risk, as I mentioned before, anti-resorptive or bone-forming agents, they have additive effect on the additive effect, complement each other. Next slide, please. So what are the principal indications? It's a really troublesome vasomotor symptoms affecting quality of life, but other symptoms too, joint ache, poor sleep, mental fogginess. Those are the all indications for MHT. When should it be commenced? Depend on the nature and the severity of menopausal symptoms. Also perimenopausal days too. It really has to be individualized. And for how long? Look, we know most of the times the symptoms of menopause, they do improve. However, in about 40% of women, those symptoms can persist to age 60 to 65. So treatment duration has to be really tailored from person to person. And then that's where we have to discuss all the risks, especially in breast cancer. Current recommendation is we do not really recommend women to start MHT over age of 60. Because a lot of times their symptoms have already improved. Also, we know because the older you are, the risk of breast cancer naturally does go up. However, I am seeing a lot of patients in their 60s who missed out that timing because of the WHI study. We have this almost 20-year period of dark age of HRT or MHT where women missed out on their treatments. And now they are getting a lot of information out there through podcasts or Instagram, and they are actively seeking hormonal therapy for their symptoms, although their symptoms may not be as bad as they were before, but nevertheless they're present. I think those patients, we have to still discuss the benefits and then, really weigh up the risks and benefit in those. Definitely women who had a premature ovarian insufficiency or early menopause, current guideline recommends continuing on MHT until their natural or average age of menopause, which is about 50 years old. Next slide, please. So during perimenopausal period, as I said, those are the times where you're still having periods, albeit irregularly, but still have symptoms. So the goals is you have to control the cycle. And also those are the times you still have to produce provide contraception and also symptomatic relief. So most commonly in my practice, I use a lot of times combined pill because their cycles become regular. and they provide a very good, reliable contraception. Sometimes, however, the patients can complain symptoms during the pill-free period, the placebo days. During those days, you can give them supplementary estrogen like a transdermal cream. Very useful. Also, when contraception is no longer needed, you can change into proper MHT. And progestin, you can use a Mirena as part of the progestin treatment, which is a reliable contraception, or patients who are using transdermal estradiol for history of VTE, or that's high risk, or patients with an aura, you can use a progestin-only pills as a contraception, progesterone, and also combine with a transdermal estrogen. Sometimes you can use a cyclical MHT, cyclic progestin during second half of the menstrual cycle for the cycle restoration, but they're not contraceptive. So they are usually only used for patients who do not really need reliable contraception. However, some of those patients may complain mastalgia or erratic bleeding. Next slide. So after perimenopausal days, hormone replacement, what do we use? So cyclic, it could be either continuous estrogen, either orally or transdermally, combined with the progesterone for 12 to 14 days of the cycle. Often it results in the scheduled menstrual bleeding, and they're very effective for their symptom control. You can actually choose continuous. You can provide a daily progesterone, or Mirena is also a very good option. About 90% by 12 months, they reach amenorrhea. However, breakthrough bleeding is very common in the first few months. And also, if they have unexplained persistent bleeding, investigations such as pelvic ultrasound, hysteroscopy, and endometrial biopsies are often needed. And every now and then, you could still have a random bleeding, ovulation bleeding. Telltale sign is patients come in with 5 or 6 days of bleeding. They usually tell you, it felt very much like a menstrual cycle. They had a breast tenderness. They had all these other symptoms they used to have when they were menstruating. Those people, you can have, you don't have to rush into pelvic ultrasounds for those patients. Next slide. So I think this is really the main topic. Look, breast cancer. So in UK, who never used HRT between age of 50 and 69, the number may be slightly different, depends on what paper you look at. The risk of breast cancer is 1 in 16. It's about 63 cases per 1,000 women. But over the same period, so if you use MHT, HRT for 5 years, you have extra 5 cases. And if you use that's estrogen only, but if you use estrogen combined with a progesterone, sequential, which is a cyclic progesterone, you have extra 14 cases on top of your 63 cases. But if you use estrogen and continuous progesterone, the number goes slightly higher up to about 20 extra cases. Definitely the extra number is slightly higher for women who are taking HRT between age of 55 and 60. So older you are, still the risk is slightly higher because of your baseline risk. And also, if you actually use the hormonal therapy MHT for 10 years, extra numbers are thought to double. So we know it's very safe for the 5 years, but after 10 years, the risk is, there's definitely a significant increase in the risk of breast cancer. Next slide, please. So women, but I think we have to really put different categories: women with a lower underlying risk of breast cancer and high risk population. So women with a low underlying risk, it's like average, Jane. The risk of breast cancer, the benefit of HRT for up to 5 years, for the symptomatic relief, it will exceed potential harm. Unopposed estrogen, which is the woman who has had hysterectomy. Those are the women who still had their studies going on WHI study. There's associated with either no or little change the risk, but it may be influenced by the age of initiation, because your baseline of breast cancer risk does go up. There's no evidence of dosage effect of estrogen, so you don't have to stick to lowest dose of estrogen possible just to be safe. I think dosage has to be titrated according to their symptom relief. Vaginal estrogens not associated with increased risk at all. Combined MHT, those are the ones with the estrogen and progesterone, they do have increased risk. However, it is duration dependent, but up to 5 years, we do have a really good, robust evidence it is safe. While risk of continuous combined MHT, as I mentioned in previous slide, may be greater than sequential cyclical MHT, the difference risk is very small and it almost becomes neutral when you consider endometrial cancer risk. Patients who are taking cyclical, sequential progesterone, they have slightly high risk of endometrial cancer. So avoidance, look, there are not all progesterones are same. Now, I think we are having a lot more evidence, RCTs coming out. There are certain progesterone preparations are safer, which is a dihydroprogesterone, a micronized progesterone. Micronized progesterone is the ones in prometrium. Dihydroprogesterone is the one combined and it's a constituent of femostin, very commonly used MHT. We have a very good observational studies. The risk of breast cancer is much lower compared to more synthetic progesterones. So if I think you should offer those micronized progesterone or dihydroprogesterone as a first-line progestin treatment. Risk associated with MHT, including the past use, is less than other lifestyle, risk factors such as, smoking and over obesity and things. So HRT actually is safer than some of those lifestyle risk factors. Women with a premature ovarian insufficiency, so it's only the years of MHT exposure should be counted from age of 50. So, even if they have been on it for 10 years, previous 10 years, because they were premature menopause, you should really start counting. They can use up to 55, for instance. So the most important thing is you really have to communicate the risk in terms of absolute excess risk. So we really have to be careful, to minimize a framing and misinterpretation amongst patients. Next slide.
Sorry, just to jump in, do you want to give any last messages before we pass it on to the next speaker?
Oh, okay. Can we just do the next slide?
Yeah.
I just want to touch base. I think some of the patients are very confused. High risk group of patients. So high risk, the next slide, it's even higher risk. So for instance, people who have a very strong family history, like a BRCA mutations or Lynch syndrome, because we are routinely advocating risk reducing oophorectomies. So for instance, BRCA8, often those women have a bilateral saphenous oophorectomy before they reach 40. And BRCA2 mutations, Lynch syndrome, they get counseled or recommended to have both ovaries removed by the time they reach 45. So is it really safe? Because those are they represent the group of women who have a strongest family history or high risk factors. And can you move on to the next slide? So those women, it is still considered quite safe for 5 years. So I'll just quickly move on. The risk doesn't go much higher, even if you have a very strong family history. The risk of dying definitely doesn't change very much for 5 years. So I think we should still offer MHT to women. They're concerned about their family history. Sometimes, a lot of those times, their family history is not really that strong either. But even with the genetic mutations, like Lynch syndrome, for the first 5 years after their oophorectomy, it's very safe. So move on to the next slide. So next slide, cardiovascular disease, there's no evidence it harms or it's an increased risk. Stroke, increased risk oral, so transdermal is preferred. Next slide. Next slide. Next slide, move on. Tibolone is something that I want you to mention. It's a synthetic steroid commonly used for postmenopausal women for symptomatic hot flushings and sexual functions. Also, it has a very positive effect, has been proven on bone density, reduction in the risk of the fractures. However, there's no increased risk of VTE. Next slide. Originally, Tibolone was thought to be very safe for breast cancer. And it was according to a lot of preclinical studies. However, we have a very large epidemiological studies, Million study, Libret study. There is still increased risk of breast cancer. So is it safer than your conventional estrogen progesterone combination? Not really. They do still pose some risk. And also, once again, same thing, it's not recommended for women with a previous breast cancer history. And Tibolone, if you use in perimenopausal women, it can result in erratic bleeding. So it's mostly recommended for postmenopausal women. Next slide. Testosterone, yes, it's only recommended for patients who have reported like hyposexual disorders. Next slide. So Endrofem is most commonly used. It takes about 8 to 12 weeks until you see the improvement. They have to be monitored for androgen excess. Usually we do measure FAI, has to be less than 5. Adverse effects, hair growth. It's very, very unusual and rare to have those severe hypoandrogenism side effects like alopecia or acne, enlarged clitoris. Those are very rare. It's very safe when you use it transdermally. It does not seem to be associated with blood pressure rise or lipid profile. There's no, so far, increased risk of breast cancer in short term, but we do not really have a good RCT evidence on it. Safety in women with the previous, once again, breast cancer history is not very clear. Next slide. Bioidentical hormones. I know a lot of patients on Troches thinking it's a lot safer. However, we do not really have a safety and efficacy profile on those. So there's no sufficient data to recommend its usage, and it's not regulated by TGA. So current recommendation is not to advise patients to be on bioidentical hormones, Troches. Next slide.
Sorry
Yep.
to jump in.
That's it. Yep.
We,
Very last slide.
we might
This
say,
slide will be sent out to you anyway. So this is just an algorithm you can follow, how managing perimenopausal and menopausal women. Thank you.
There were a couple, if Dr. Yang's still there, there were a couple that we could do. So if someone's had endometriosis, would you recommend that they have progesterone as well as estrogen, or they're happy with estrogen only?
Oh, the ones after hysterectomy, yes. Even if they had a hysterectomy, they should still be on combined because you could still have some endometriotic cells deposit in the pelvis and they respond to unopposed estrogen. So those are the ones who we recommend combined. Those are the ones who had endometriosis and a hysterectomy.
Thank you. And a common question actually is when to change sequential MHT to continuous MHT in the perimenopausal patient.
I usually, personally, I use a cycle as a guideline. Often you see patients who are taking sequential HRT or MHT, and they seem to have less of the withdrawal bleeding. And then I kind of know that's a time to change into more continuous HRT.
Thank you. And how do you best assess someone is postmenopausal if they've been amenorrheic, sometimes for, a decade or so because they've had the Mirena, for example?
FSH still is useful with the Mirena.
Thank you. And are the effects of breast cancer lower with prometrium versus the older synthetic progesterones?
Yes. Yes. So prometrium and famotidine, they seem to be body identical progesterones. Yeah.
And if your a patient coming off her MHT in her 60s, as her vasomotor symptoms have improved, but they come back, would you potentially restart MHT again?
Oh, it really depends. Yeah, I think it's individual. Depends when they return with the symptoms. But try not to. But it's a personal choice at the end of the day. They have every it's their autonomy. So I've got patients who were told to go off HRT, MHT, and then they come back being rather miserable with hot flushings. And, those are the ones, they understand the risks, and then they're very vigilant with other screening protocols, breast cancer, then I'm happy to restart, but try to be very careful.
Mm. And what about patients with that are on Tibolone but haven't got a previous breast cancer history? Because obviously you've already discussed that Tibolone does increase risk of recurrence, but those that haven't had breast cancer, is there an increased risk of breast cancer with the Tibolone?
Yes, yes.
Yeah. And increased risk of breast cancer in women using the Mirena plus the estrogen therapy.
Is it compared to estrogen and conventional progesterone?
I believe that was the basis of the question, yes.
Yes, I think the dosage is probably lower. So progesterone level, you can, because they just directly go to the endometrium, this is where you wanted it, for endometrial protections. So you can get away with a less dose of a progesterone. So conventional progestin, for instance, like a medroxyprogesterone, MPA, I think is safer.
Yeah.
Because of the dosage lower. But is it safer than micronized? We're not so sure yet, because we are only just starting some evidence of micronized progesterones.
Mm-hmm. Okay. And when should we stop HRT or MHT?
MHT. I think we should, after 5 years, there should be a trial period of, if they have, but if they start to have resurgence of other symptoms, we can always discuss. I don't think should be a set rule. We know the 5 is safer, so they should feel very comfortable continuing for 5 years. But afterwards, it's really depend. But I usually recommend patients to have a kind of trial period without HRT for a few months. And then if they are happy, they don't have to be restarted. But if they start to get other hot flushings, other symptoms, yes, I usually restart. And then try that every 12 months or so.
Okay. And can someone confidently use Avestin in patients with a history of breast cancer?
Yes.
Yeah.
So
Okay.
level of estradiol in the blood, home is undetectable almost. Yes.
Okay. And someone who's had a hysterectomy and with oophorectomy, are patients, because of the family history of breast cancer, can they still use the estrogen patch?
Yes. So those are the ones I mentioned, risk reduction surgery because of the BRCA or Lynch syndrome. Up until age of 50, they still have a similar risk as like everybody else. So it's safe to use. After 50, 5 years, yes, but
Thank you.
afterwards, should be individualized.
Okay, I will pass on to Dr. C. There's a few more questions in the chat as well.
So I'm going to spend the next 20 minutes on female stress urinary incontinence, which is one of my pet topics. It is a very common problem affecting about 20 to 30% of younger women, and after the age of 60, up to 50 to 60% of women have experienced some form of stress urinary incontinence. Next slide, please. So I'm going to start with the first couple of minutes on some aspects of bladder physiology. So the urinary tract has a bladder which stores and empties, and the urethra as a conduit for urine. Next slide, please. So if you look at the difference between the male and the female lower urinary tract, on the female and the male both have a internal sphincter, which is now called the bladder neck mechanism, and also an external urinary sphincter, which is now called a rhabdosphincter because it's controlled by skeletal muscle. And then the female, you can see the external urinary sphincter, the rhabdosphincter, is a very long cylindrical structure, which goes from the bladder neck all the way towards the urethral meatus. And it's very thick as well, about 5 millimeters thick. Next slide, please. Can you keep going with with the slide. So with lower urinary tract symptoms, we have it's in a biphasic theme. You have storage and voiding, because that's what the bladder does, stores and voids. So you have storage dysfunction and voiding dysfunction. And the storage dysfunction gives you frequency, urgency, and nocturia. So these are, they used to be called irritative symptoms, but now they should be called storage symptoms. And when you have these symptoms, you think about storage problem. You know, does the patient have a storage problem? Now, versus voiding symptoms, which are hesitancy, poor flow, terminal dribbling, these point more towards an emptying dysfunction. And of course, they used to be called obstructive symptoms, but they now should be called voiding symptoms, and then storage symptoms. And many patients have mixed symptoms. Next slide, please. So in trying to understand, bladder dysfunction, the easiest way is to look at this 2x2 box. You have storage dysfunction on one side and voiding dysfunction on one side, on the other side, and you have bladder factor and outlet factor for each. And I find understanding incontinence like stress, urge, giggle, overflow is very confusing. But this is a very simplistic but very useful way of understanding bladder dysfunction, is this 2x2 box. So if you superimpose some common conditions onto this table, you'll get something like this. Next slide. So if you look at the left-hand side, under bladder factor, the most common storage dysfunction is urinary tract infection, because it gives you frequency and urgency. The next most common is detrusor overactivity, which presents with urge incontinence. And of course, bladder cancer can also give you urgency and frequency, so that also classify under bladder factor storage dysfunction. And if you look at stress incontinence, which we're talking about today, it is actually an outlet factor storage dysfunction. And on the right-hand side, you have the bladder factor and the outlet factor for voiding dysfunction. And the most common one is actually right in the corner, which is enlarged prostate for men. Gives you an outlet factor voiding dysfunction. Next slide, please. So I want you to understand that there is a two-phase concept of normal storage and normal voiding. And then when you have dysfunction, you have storage dysfunction and voiding dysfunction. And stress incontinence is a storage dysfunction bladder factor. Outlet factor. Next slide, please. Next slide, please. Yeah, so basically, stress incontinence, as I said, is a very prevalent issue around the world. And stress incontinence itself is both a symptom and a sign, but it's not a diagnosis. The diagnosis can only be established after a urodynamic study, which proves that the incontinence occurs purely with physical activity, such as a cough or a Valsalva, without the evidence of a detrusor contraction. And you can only do that when there is a pressure line in the patient's bladder during a urodynamic study. Next slide, please. So what is the cause of female SUI? Well, if you look at the continence mechanism in the female is very complex. You can actually use a scalpel to cut right across the female sphincter and then stitch it up again, and the patient will not be incontinent. Why is that? Because there are multiple mechanisms for the continence mechanism, not just the sphincters. You have pelvic floor support, the levators which support the bladder, as you can see, like a hammock, and you've got various ligaments that support the urethra in the pelvis. And of course, you have the rectal sphincter, the external urinary sphincter, which is like a washer in a tap. So next slide, please. So what's wrong when 1 and 2 are deficient or defective in some way? Well, you will have stress incontinence, but because there are multiple mechanisms, the two most common will give you the two most common type of stress incontinence. Type number 1 is called urethral hypermobility. It is a bit like if you put a hose on the floor, like a water hose on the floor, and you stamp your foot on it, the water hose would get squashed and water would stop coming out. So this is like a normal, a patient with a good pelvic floor. the hose is the urethra, and the stamping is like a cough or a sneeze, because you've got the underneath, which is strong, so the urethra is compressed. But if you put the hose on a trampoline, and you stamp your foot on the hose, underneath gives way, and the hose won't be shut off. So that is urethral hypermobility, is you've got weakened pelvic floor support. So that's the easiest way to understand the urethral hypermobility concept. And then the weak rectal sphincter is like a loose washer in a tap. If you've got a loose rectal sphincter, you cannot compress the urethra, and then they leak. So people with hypermobility tends to have higher, it's more difficult for them to leak. They have to cough hard or sneeze or laugh to leak. Whereas patients with a weakened sphincter, they don't have to cough much at all. Even when they're just walking around with minimal activity, they can leak because the washer is loose. So therefore, the seal of the urethra is not there. Next slide, please. Yeah, so this is just a simplistic diagram of the trampoline effect. When they cough, you can see the underneath of the pelvic floor gives way, leading to sagging of the bladder neck, and the bladder neck distracts open and urine leaks out. Next slide, please. So the most current concept of stress incontinence in a woman is that they have to have sphincter deficiency, ISD. They must have some sort of loose washer in the tap. The hypermobility is not so important. You can have ladies who have very hypermobile pelvic floor, but if they have an intact outlet, intact washer, they should not leak at all. So the modern thinking is that there must be some sort of sphincter deficiency. Next slide, please. So the history and examination are fairly self-explanatory. They typically leak with physical activity, such as picking up children, cough, laugh, spawning activities, high impact activities. They may also have associated overactive bladder symptoms. And we've got to examine their lower abdomen and vaginal examination for urethral atrophy or vaginal atrophy and associated prolapse, because they may mask incontinence as the bladder, as a cystocele kinks the urethra, it can mask stress incontinence. And also in patients you suspect having some neurological issue, we should also do a brief lower limb neuro exam. Next slide, please. So investigations are reasonably simple. We're just going to make sure they do not have a UTI that have exacerbated or caused the incontinence, especially in older women. And also we have to make sure that they have a post-op residual urine, usually with a bladder ultrasound, to make sure they haven't got avoiding dysfunction. Urodynamics would be a specialist. Once the patient is referred to the specialist setting, we may then decide to organize one, especially if they prefer to have a surgical procedure. Next slide, please. Now, it is very fair to have to talk about conservative management for stress urinary incontinence, usually in the setting of Kegels exercises. They can be effective in up to 75% of patients within a 6-month period. And there are brochures from the Continence Foundation of Australia. In that web address, you can see there, you can download free brochures for patients for pelvic floor exercises. And also have to reduce abdominal strain conditions that may lead to that are listed there. And also, if they have overactive bladder, they need to be investigated with bladder diaries, and also trial of empirical medications such as antimuscarinic or beta-3 agonist in conjunction with bladder training. And as Vivian Yang just spoke about topical estrogen, it is very safe to use at any age, even in patients with breast cancer. It's very important if they have overactive bladder component. It doesn't really help with stress urinary incontinence, but it certainly helps with overactive bladder symptoms that are idiopathic, Next slide, please. So let's spend the last 6-7 minutes on what are some surgical options available. Next slide, please. So if you failed conservative management, then the treatments are aiming to what we call increase the leak point pressure, which is to increase urethral resistance. And there are a number of options, as you can see there. The most invasive is the outside circle, which is implanting an artificial urinary sphincter, which is extremely rare that we have to do that. But the more common procedures are down in the middle or in the midsection, such as slings and bulking agents, and such as a Birch-Copeland suspension, or the use of a fascial sling if the patient is adverse to mesh. And because most ladies have mild to moderate severity of their stress incontinence, the artificial sphincter is useful in the most refractory of patients when they fail all slings or bulking agent options. Then the artificial sphincter can be implanted in suitably selected patients, which is the penultimate procedure for female stress urinary incontinence. Next slide, please. Yeah, so as the severity of the sphincter deficiency gets worse, you have to go towards the outside of the circle. Next slide, please. So for hypermobility, the most commonly done procedure is the mid-urethral mesh sling, which can be either retropubic route or transobturator, and also the Copeland suspension procedure, where a hammock is strengthened by stitching the anterior vaginal wall on each side onto the Cooper's ligament on the pubic bone. It creates like a hammock to support the bladder neck. If you like, putting a concrete floor back into that section of trampoline so that the urethra doesn't sag down and gives way. Now, sphincter deficiency, ISD, intrinsic sphincter deficiency, means deficiency of the external urinary sphincter. And I explain to patients like loose washer in a tap. So you can either seal it with silicone, similar to in the shower screen when there's a crack, you have to put silicone gel. So very similar to proximal urethra, you can seal it off with bulking agents, such as Bulkamid, which is commonly available now. And it's a minimally invasive procedure, which should be considered in all women with mildly bothersome SUI, or in the frail elderly, also, because it only takes 15 minutes to do. Now, for the fit and more healthy patients, they may not like the bulking. They may want to have a slightly more robust procedure, because sometimes the bulking may only work for a couple of years and they may have to come back for top-ups. But if they wanted a more durable procedure, then they could opt for the slings. Now, let me spend a minute on the mesh, because I was involved in the Senate inquiry for as you know, there's been a bit of a mesh issue over a number of years now. And thank God that I think the dust has settled somewhat now. But we fought and fought and fought. It is still available in this country because it is still a very useful procedure, and it's been deemed safe and effective in most learned societies in their position statements. So we managed to keep the sling because it's still useful in selected patients. But there are also patients that do not like it, but there are actually some patients that come and ask for it. So I don't think we should throw the baby out with the bathwater, to be honest. So, but if they really don't like the mesh, then there's a native tissue, which is the Birch-Copeland suspension, which has been used over 60 years. And also the fascial sling, which is harvested from the six-pack muscle, which is also non-mesh, and it's very safe as well. But all slings, whether they are mesh or non-mesh or Copeland suspension, carries a small chance of temporary urinary retention. And sometimes if they don't pass their voiding trial, they may need to undergo sling loosening or taking down the Birch-Copeland suspension. And as I said, the artificial sphincter is the gold standard if they fail all of the above. Next slide, please. So, this is a picture of the mesh sling, which is the most commonly done operation in the world. Just because some countries have banned or paused the mesh, it doesn't mean that it's necessarily very bad, because many other countries have carried on using this sling, like in Europe and North America and Latin America. They're still using this because it is still safe and effective for most women. Next slide, please. So next slide, please. Now, so I just threw a slide like this in there because there are some mesh complications, and if they want to have the mesh, we need to let them know that these may occur, but it is very rare. And if it's detected early and we follow the patients up very, very carefully, this will not be missed, and they can be managed reasonably easily. And also, even if they choose a native tissue repair, it doesn't mean that there are no complications. You know, every operation has complications. So we need to present to the patient in a neutral fashion each of the options, and we must not have internal bias of one preferred over the other. We should be neutral in the presentation and let the patient think about it. And if they have questions, they ask us, and until they reach a decision. And I do not think we should have internal biases when we actually recommend treatment options. Okay, so from here onwards, I would like to conclude by saying that the other option is, of course, is the fascial sling, which we harvest from the abdomen over the abdominal muscles, and they are inserted very similar to the mesh sling, but the cut is slightly bigger, and it obviates the use of mesh, but they can also cause retention. Sometimes they also have to be taken down and loosened. But it is certainly more commonly used now together with the bulking agents in the mesh adverse patient. And of course, the artificial sphincter can be also used in a very, very selected few patients who have failed almost everything. And they wanted one more, they only have enough reserve for one more operation. And the really motivated one, we can implant an artificial urinary sphincter, similar to the men after prostatectomy, but instead of putting the pump in the scrotum, we put it in the labia major, which is the same embryologically as the scrotum. So the pump is placed in the labia major, and the patient squeezes the pump in the labia major, and they can open the artificial cuff, and they can void, and then the cuff closes automatically after 3 minutes. So it is really useful for patients who have almost no urethral function, almost like a lead pipe, and we can implant that sphincter to help their incontinence. So
Thank you.
On this note, I'd like to thank you, everyone.
Thank you so much. That was really useful. There is just one question, just quickly, just to wrap everything up. Young woman in their 40s with a low BMI and stress incontinence. Briefly, what options are there available for
low BMI and stress incontinence?
Yeah.
So a slim woman. Well, it's actually many. I mean, they fail conservative management. And they just have mild incontinence, they can have a bulking agent. And if they're a young patient, I may not necessarily recommend a mesh, because they may live long enough for mesh complications to come through years and years later. I may offer a native tissue option such as a pelvic suspension or a fascial sling. But in an older patient, much older, say 70s or close to 80, mild maybe bulking agent or a mesh sling would be quite good. Yeah.
Thank you very much. Thank you, Dr. C and Dr. Yang. Some really big, huge subjects there. I believe I just need to hand over to Serena now for the end of this webinar. Thank you.
Thank you. I'd like to extend my thanks to Vincent, Vivian, and Joe for presenting, and to everyone joining us online. So we do hope you enjoy the session and you also enjoy the rest of your evening. Thank you and good night, everyone.